I think it's always a little difficult to speak about breakthroughs because these happen on and off, and there's always I always say there's also many small iterations, many small changes that happen. This may be technology, this may be technique, this may be the approach from a logistical point of view, from workflow point of view, which make a difference. And the sum of these can change the way we do medicine, or ophthalmology in this case. I don't think it makes any sense to highlight some new technology or some new technique, because that's only part of one big sum of many things. There are some hot discussions at the moment, and we try to highlight some of these in the arena. You may have been to the arena and in Vienna at the ESCRS, a new format where we try to have debates on hot topics. And I think one of them, from a logistic and from a workflow perspective, is the idea of doing immediate sequential bilateral cataract surgery versus sequential, doing both eyes on one day. We know we can do that. Many of us used to do that for general anesthesia cases anyhow. And also now, of course, with COVID, we had to revert to IBSCS. And now there is some good data that it seems to be cost effective to do that. There's also less travel for the patients. But the problem is also, on the other hand, that many countries don't pay as well for the hospital, for example, if you do both eyes on one day than if you do them separately. So there's a lot of issues. I think that's a hot debate over the next year. We'll see a lot about that. And I think it's going to change a few things in our, let me say, daily work. Concerning technology, I think, the digital operating room is something which is obviously becoming more and more, not only fashionable, but it's also becoming more and more evident, for many of us, is a big help, both for safety as well as for efficacy and efficiency, especially. So we had some sessions on that at ESCRS. We had essentially a whole digital day on Monday focused on that. And one of them was the digital operating room, robotics, which is becoming something which is, I think, is going to be a big game changer possibly. And of course, AI, as you know, is also an anterior segment surgery, especially diagnostics. So I think we will see quite a bit of change in this arena as well, from my perspective. And then we had one very interesting main symposium on Friday at the Congress, which was about who owns ophthalmology. So this issue, of chains and private equity taking over many practices and surgical centers. And I think that is something which going in a direction which I believe is not only in the interest of patients and not only in the interest of ophthalmologists. So I think this is something we need to discuss. Also, maybe also show some resistance to these trends, because I think that from my perspective, in some instances, they're going overboard. First of all, we started Mission Zero last year, right? Vienna Congress in itself, including the travel of the delegates, was carbon neutral. So that's, I think, good to know. And obviously we did that by reducing carbon emissions, by all kinds of things we did, and also trying to reduce plastics and disposables and so forth. But also by offsetting the carbon footprint of the travel through NGOs, 5 NGOs, usually in the low and middle income countries, where we can sort of compensate our carbon emissions to a certain extent. And I think that works quite well. And I think so we're really happy that has worked. And so that's the one part, is trying to make the Congress more sustainable. And the other part, which is as important, maybe even more important, is how can we change our daily life, our daily working life in the operating theaters, even in clinics? How can we reduce our carbon footprint? And so we had this project which we started last year, which we now have ready. It's a so-called SIDIX calculator, so Sustainability Index for disposables in cataract surgery. And it's a calculator where you have your cat packs, where you have your knives, your gowns, you have your drapes, everything is inside, right? With the syringes, with the cannulas. And we have these cat packs, and we have them made, custom made by many different companies. And so we use these cat packs. And the problem is that some of these cat packs, and I can also talk about ours, the one we have in our hospital, has things in there which are not really necessary. We have some things we only use sometimes and not every time. We've seen some cat pack with very, very large drapes which go down to the feet of the patient, which is not necessary for cataract surgery. Together with the university, we developed this calculator where you can enter your cat pack, click, 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 what you have inside, how big is your gown, how big is your drape, how many syringes do you have, how many cannulas do you have, and so forth. and then you get the carbon footprint of that CAD pack. It's of course, generic. It's not company A, B, C, D at this point, but it's sort of a good average of several suppliers. And we also defined a so-called ESCRS benchmark CAD pack, which is the lowest common denominator of what many surgical centers in Europe are using, which we did a survey on that. And so I think it's good to go and take your list, your CAD pack list, click, and then actually see where do you stand compared to the benchmark set. And then you can say, maybe I don't need this, and maybe I don't need that, and maybe I can make my drape smaller. And I think that will help to reduce carbon footprint significantly, because we use these every day, and that cataract surgery is the most common surgery, full stop, in medicine, not only in ophthalmology. So if we make some small changes there, that has significant impact. So from my hospital, changing now to the smaller, the so-called benchmark pack, has reduced the carbon footprint by 30% without any compromise in safety. That's the important thing. No safety compromise. So it's just, you have to change your routine maybe slightly. The nurses have to adapt. We have to adapt as surgeons, but that's doable. So I think, our CAD pack we've had since many, many years, nobody thought about changing it. It was just, it works. Yeah, of course it works, but it's unnecessarily big. So I think, we have to rethink, and everybody has to do that for himself. And they have to decide what they want to leave away and what they don't need or what they need. And I think that can change quite a bit. So CITIC's calculators online on the ESCRS website. We've done a lot on sustainability, also trying to inform people what can they change, what can they change quickly. We had a main symposium on it. We had an arena session on it. So we had one instructional course on it. So we're trying to also just inform, motivate, hopefully, and just I hope that will induce some change. Let me say it that way. I think, this whole issue about monofocal plus and EDOF lenses, right? And which box do you put this lens in? Let's say, company X, company Y, where does it fit now, this lens, right? So we like to have the EDOF box, and we like to have the monofocal plus box, the monofocal, the trifocal. But I think we have to think a little differently. Yes, monofocal is clear, trifocal is clear, but in between it's a continuum, right? From monofocal plus over EDOF or whatever you want to call it, down to bifocal, trifocal, right? And I think we need to slightly change our attitude and our thinking about that, and just think this lens has specific characteristics, optical characteristics, and who is suitable for this lens, or for whom is this lens suitable. And I think that's the most important. And obviously, as a surgeon, you cannot have 20 products, because you only use one every few times. So ideally, you want to have 2, 3, 4 products of, presbyopia correcting lenses, which you know quite well, and then you need to know where you use it with whom, and whether you combine it with monovision, or you just keep it for distance for both eyes. And I think that's what we need to do, is we need to change slightly our thinking about these lenses, and just try to understand what this lens from this manufacturer is actually doing. And I think that's something we need to do. And it's not easy, because it's always, there's many different data points. Companies tell you all kinds of things, of course, even very fancy names for some new technology. But at the end of the day, it's always about splitting light to a certain extent, or stretching light. And you're always going to have some compromise. And the question is, how much is a compromise concerning quality of vision, concerning dysphotopsia, contrast sensitivity, maybe even distance acuity. So I think that's something we need to sort of find a better way of characterizing and describing. And hopefully that will also then be helpful for doctors, for surgeons. Obviously, my successor, Filomena Ribeiro from Portugal, who will be the president starting January 1st. I'm still the program committee chair until the end of the year, and we're planning a few new formats where we would, that's my interest, and I think also Filomena's interest, as far as I know, and to try to have more of a networking experience, more of a getting together and doing something together, and especially for younger ophthalmologists, not only young, for everybody, but maybe even more interesting for young ophthalmologists. So the idea that you really have the possibility of interacting more. So we had that in the arena. In the arena, you were able to write a comment or question. It came up as big bubbles on the big screens, right? So you were able to really participate, and you were able to vote by walking around and saying, I'm for red, no, I'm for blue, or I don't know yet. So, you have much more of a dynamic, interactive style than just sitting there and listening to somebody talk. So I think that's something we want to push. Having networking events, there's many different formats, which we're thinking about. I won't tell you yet, because there should be some surprises. For example, 5 or 6 young ophthalmologists, or not only young ophthalmologists, to really get together and work together for 45 minutes to solve some problems. Thinking about doing world cafes where you maybe interact with people from industry, from research, from development on different topics, structured. So I think you'll see quite a few interesting new formats coming up, which are out of the norm, which I also have never seen with other congresses, no matter ophthalmology or non-ophthalmology, which I think are really new. So, and then we'll of course still have our main symposia, because that's in 2 hours you get all the information you need on that topic from 6 very eloquent international speakers, and then 2 chairpersons. So I think that we'll obviously keep to that format as well. But I think we're looking at some new trends, some new methods, let me say it that way. And I said I wanted to have a poster presented with a small group of 15, 20, 25 people sitting there, more informal. People can ask questions. It's much more close than if you are from a stage. So that has gone down very well. Also the free paper sessions, which we now have in 4 booths in one big room, is also a format which we introduced a few years ago. But now we also saw with COVID that many, wanted to change to virtual, especially the younger generation thinks, should I go to a congress? I can also watch it on my screen. Yes, you could, but you can't really interact. So you're sitting, you're very passive, you're very far outside. You can write a comment, yes, okay, but it's not really taken up. And I think that's where we want to go. We want to really make the congress much more of an interactive event where you can actually really interact with speakers, key opinion leaders, colleagues, friends. Yeah, I think cost will be a big factor, and who will do the work? How well can we delegate? Can we delegate even more than we do now? Because it's quite clear, if you look at the age pyramid, more and more baby boomers are coming now into retirement, and then we'll also get typical diseases, cataract, glaucoma, and so forth. So how can we take care of this at least in the Western world, definitely enlarging population, and the doctors tend to become less, or at least stay the same number. Nursing is becoming a real problem in Europe, as you probably know, especially since COVID, even more so, but also before. We have a shortage in nursing staff. So hospitals now need to think about alternatives to just doctors and nursing, but get more technicians in, get more people in to do, diagnostic steps and so forth. I think that's going to be one of the biggest challenges for most countries. So how well can doctors delegate? And of course here, telemedicine, AI, yes, maybe robotics can help, but I'm not really sure about telemedicine, to be honest, because I think, you still need to see a patient. Of course, if technology really develops even more, maybe it's possible to do that from far away, but still you need a doctor to do that. So I'm not so sure that telemedicine is going to be a big answer, at least for most countries. Maybe for some where you have very, very remote places for patients, that's maybe something different. But in most European countries, that's not such an issue. So I think from the way we work and how do we delegate and who owns that? Is it a chain who puts pressure on you, of course, because they want to make profit? Then you get into all these issues, which I think that those are going to be the big challenges. How can we keep a good, effective, and efficient public healthcare system up and running? So I think for many countries, that's a big question. For some countries, it's already gone, and they've already lost it. They're already privatized to a big extent, and others aren't at all yet. So I think that's going to be something which is going to be very challenging. It's a little abstract, so it's not so easy to talk about, but biggest challenges of the next few years for most of us in Europe, at least. And otherwise, digitization, and robotization is obviously something which is coming down. I think it's going to go not as fast as we believe. It's going to take longer than we all believe. And also AI is not going to be so helpful, especially in anterior segment. Yes, there will be some, I think it'll be helpful here and there for that and this, but not as much as we believe it will. I think it'll take much longer. Yeah, long, so short question, long answer, don't know.
Thank you so much. It was a great answer.
Sorry about that. We're getting very philosophical.